Good afternoon. Okay. Dear my colleagues and guests, it's my honor to say welcome to all you in Kyrenia, a historical and cultural place at the middle of the Mediterranean. Why Kyrenia? Kyrenia is a natural harbor, once so attractive in the history with ample ambition, and today is a favorite touristic place which two different nationalities lives with peace. Most of us is working as a reproductive medicine specialist. In the past 30 years, the world of the reproductive medicine is evolving rapidly. It is generally accepted that contemporary ART is approaching its limits. But still we have lots of questions to be answered. In my opinion, personalization may evolve treatment strategies in ART. And also it gives us the opportunity to systemize the problems and make it easy to solve. Although the term personalized medicine was first used as a title in 1998, it has a histological background that grows parallel to medical concept, and also physicians have traditionally practiced personalized medicine in their attempts to decide the best treatment of their patients. There is no official recognized definition of personalized medicine, as oncologic field is the pioneer in the application of personalized medicine. U.S. National Cancer Institute defined it as a form of medicine that uses information about a person's genes, proteins, and environment to prevent, diagnose, and treat diseases. Lots of factors are involved in the development of personalized medicine, but the mainstay of the developments is molecular biology. The progress in study of human disease at molecular level, drug development based on genomics, proteomics, metabolomics, and biomarkers, and developing bioinformatics made it more powerful. Various development in this field make a shift from population-centered to individual-centered approaches for prediction and prevention of the diseases. There are some successful attempts to make healthcare system more multidimensional and prevention-oriented. Not only prediction and prevention, but also targeted treatment strategies are adapted successfully to modern medicine. Personalized medicine in ART is still in its infancy. Most of the ART specialists prefer to adopt clinical and laboratory approaches based on the best evidence-based data available or the best expert opinion of the attending clinician. Evidence-based medicine and personalized-based medicine are not controversial approaches. They are complementary approaches. However, they use different methodologies, whereas the evidence-based medicine approaches focuses on using RCTs to establish the best treatment for the average patient and ignores the outliers. Personalized medicine focuses on the outliers. Important basics of personalized medicine are derived from basic translational and regulatory science. In reproductive medicine, in addition to classic single molecular markers, next generation sequencing, single nucleotide polymorphism, macroarray analysis, and mass spectrophotometer can be used for personalized diagnosis with the additional of bioinformatics. Example of personalized medicine, care in reproductive medicine is limited, and we should jump from the single biomarkers currently used to more comprehensive molecular tests. Inspired by this fact, in this Congress, we primarily aim at creating a unique and interactive opportunity to discuss contemporary personalized reproductive medicine, not only summarizing up-to-date results, but also by understanding the recent scientific progress which can lead to a better clinical and laboratory practice. Future prediction shall be accompanied by these interactive controversies. Each section and topics will be covered by speakers who are also international experts and opinion leaders in their area of research. Dear guests, I must also acknowledge to Professor Carlos Simon for his great effort to this organization. We believe that qualified scientific program as well as exciting social environment coupled with the relaxing atmosphere of Kyrenia will be a unique opportunity for all of us. I wish you all a plentiful Congress and enjoyable time. Thank you very much. After this, I would like to invite Dr. Carlos Simon. He will talk about interesting subject.
I may need a pointer and...
Pointer var mı?
Well, good afternoon to all of you. It's for me a pleasure and an honor to be part of this meeting. And I want to thank you, Professor Bahçeci and Nekati, for involving me in the organization, in the scientific organization of it. I'm very happy to be here in your country, and it's my first time here in Cyprus, so it's quite of a new thing. And also I bring part of my team with me, and we will like to share with you all what we have and to be able to learn and to exchange knowledge with all of you. The presentation that I'm going to do is as the starting part of the meeting. It will be about exactly the personalized reproductive treatment. Can you hear me? Yeah. It's going to be about personalization. The first thing that I would like to do is just to disclose you that I am the scientific director of iGenomics, and some of the tests that I will be mentioned during the conference, they are part of it. But let's go to the point. And the point is exactly what you have here, which is personalized medicine. Personalized medicine is based in something that is not new, and is something that we all know, that two faces are not the same, two bodies are not the same, and they are not react alike. And we know that as a doctor. And this is because biological variation, mutations, and this is what we have to consider when we are in front of our patients. And in reproductive medicine, I think that we all know this in ovarian stimulation. So the effort that I'm going to ask you to do is to try to extrapolate, to try to make this effort of personalization in all parts of the pipeline when we have our patient in front of us. We are very careful about ovarian stimulation. We are very careful about BMI, about FSH, AMH, antral follicle count. But at the end, we do the same. So let's open our mind and let's try to personalize the whole protocol for that. And I just want to add this, which is something that I have always in my mind. This lady was twice the Nobel laureate winner at the early of the 20th century. This is Marie Curie. And she used to say this, that nothing in life is to be feared, it is only to be understood. Now is the time to understand more so that we can may fear less. And this could be applied for implantation failure, this could be applied for genetic diseases, this could be applied for why we are not as good as we should in terms of pregnancy rate for our patients. So I think that the effort here is to know more, to do more research, properly done, proper clinical trials that at the end can give us to the right conclusion for the best of our patients. So, and this is just an example that I use always to mention. This is what happened 60 years ago, in which basically we knew about a disease of the blood, which is the leukemia. And at that time, everybody dies because of that. 60 years later, we have now more than, 38 leukemias, 51 lymphomas, and the survival rate is more than 75%. So this is the best example of personalized medicine that I can get for you. And I think that if we can do that for reproductive medicine, we will be better off. This is what we are here now, and I think that you know this data, so I don't want to bore you with you, but what we have done, starting with Professor Edwards, has changed the way that humankind reproduces. More than 7 million babies born, percentage of the population in Europe born with this technology, more than 1.5 million IVF cycles per year. This is what we are doing. So we have to be excellent. We have to try to do our best. What is our mission? Our mission is not only to see the picture in small parts. Our mission is not only to get more oocytes, better oocytes. It's not only to get embryos. It's not even to get a positive pregnancy test. Our mission is to deliver healthy baby at home. And for that, we have to consider again the whole point, from the moment that the patients start with us, trying to avoid the genetic risk and trying to improve every part of the process. Science is getting absolutely outstanding in these days, and you know that there is no limit. The limit is the sky, whatever the sky means for us, because nowadays we can create biological life from chemical structures, and this has been demonstrated last year. We can do gene editing. We can correct mutations by changing the genes completely, cutting and paste. And recently, this is the breakthrough of the year in science, that we are knowing what happens even after blastulation. We are trying to understand gastrulation now in the human situation. Yesterday, there was a publication in Nature Communications in which early premature fetus, this was an animal model, they were just replacing the uterus back in order to be able that they get a better outcome, a better survival than the actual situation. So everything can be done if we are doing properly. That's the point is science is great, and we have to take advantage of the moment in the history that we are living. So what I would like to go is briefly to give you some highlights of what could be the personalization, how I view the personalization in the building the future of personalized medicine in reproductive medicine, going through these 4 points. First, the genetic risk of the couple. We have to be sure that deliver a healthy baby at home. Usually, you know how important is that. You know that 20% of infant mortality is due to those genetic diseases that we cannot forecast, except if we analyze the fathers, of course. And until now, we have started sometimes with one disease, cystic fibrosis, with 2 diseases, but just because of that, nowadays we can really do a huge amount of work on that. As indicated, we start with target diseases, then we move to larger panels. Nowadays, we are able to do, as I will show you, more than 600 genetic diseases, and very soon, the exome is available. You know that the exome could be done probably for less than 1,000 euros, and this will be probably the way that it will evolve. But for now, this is the test that we have developed. It covers these 600 genetic diseases. We are doing this by next generation sequencing, of course, and we are doing also separate tests for these hemophilia A, alpha thalassemia, X-fragile, AME, and hyperplasia adrenal congenita, because they cannot be done by NGS. And we published this is the work of Julio Martin. And by using this test, we report that in these 2,500 tests analyzed, we find out that the majority, 85% of you and me, we carry recessive genetic mutations or links to the X chromosome. I did myself, and I have 3 genetic mutations. And in fact, you can see here the curve of the percentage of that. And when we do in the same couple, 5% of them, they coincide in at least one recessive mutation, which means that 1 in 4 of the embryos or the babies will be affected and will die for that. So this is what we have learned, and this is published, so you can see that. So 85% of individuals, they have mutations using this panel. I imagine that by using the exome, this will be even higher. But the point here is that once the mutation is identified, we can analyze at the same time in the embryo. Once we do the DNA analysis, we can do the chromosomal, but also the genetic part to be sure that this embryo is genetically normal and chromosomally normal. So with that, it will be able to prevent. 5% of tested couples, they have this problem, and we are using this for the donors, so at least we know that the donors, we know the mutations, and we can do just a blind matching with the recipient. You don't need to discard donors, but we need to be sure that the donor does not share any mutation with the husband of the recipient, and therefore we are avoiding these type of problems. This is the calculation that we have done. Nowadays, we have analyzed more than 10,000 individuals, and we have prevented the potential birth of 24 affected babies. I think this is so you can have the numbers there in front of you. What about the embryo? Well, the embryo, as you know, you can see it in a particular pieces, but at the end of the day, the embryo is everything together. It's the morphology, whether you see the morphology static or morphokinetic, is the ploidy. The ploidy is fundamental, is key, because whatever the morphology is, if you have an abnormal embryo, you know what is going to be the end, either a miscarriage or even an affected child. And there are many things that they are ongoing to understand more about the genetic viability of the embryo and even about the energy part with mitochondrial DNA copy number. So all of them needs to be put all together in order to have a best understanding of what could be the best embryo to be transferred. I think that techniques, they are helpful, but we cannot be just marry with one technique. Techniques are just tools. Our mission is to have the full understanding, in this case, of the embryo. Certainly, PGS, certainly the chromosomal analysis of the embryo has been an enormous advance because this is the starting point. As you know, everything started in the 90s with the first version analyzing a few chromosomes by fish, which was an objective technique. Nowadays, we are moving to the full karyotype with next generation sequencing, and also they're accessible to the care and to the patients. and we can also add the mitochondrial DNA copy number, and we can also add the investigation of the specific mutation if the couple has already been identified as a risk that they share a specific mutation. When this analysis to be done, I think that is clear. More and more, we are moving to the blastocyst stage, to whom you have randomized clinical trials already in the general population. There are 3 clinical trials, 2 of them giving a lot of visibility and a lot of improvement of analyzing the embryos before to be embryo transfer. But also you have a specific clinical trials, and I don't want to elaborate on that because Carmen Rubio, who is the first author and the person that is working with the chromosomal department in our institution, she will present this to you. This paper is going to be published in 2 days in Fertility and Sterility. This is the randomized clinical trial in which Carmen compare what is the outcome in a randomized manner in patients undergoing PGS from 38 to 41 years old, and you will see the results. I just want to show you this slide. I cannot resist. This is just time to transfer. This is pregnancy rate, delivery rate per transfer, and delivery rate per patient, whether you are using the PGD-A, which is how it's called now, or just the blastocyst group without the analysis. As you see, there are significant improvement and the time to pregnancy, and also we have incorporated in this study a cost effectiveness study showing you that the fact that you do this is not even more expensive. It could be cheaper than if you don't do this. But she will present it to you in detail, I think, tomorrow. Cryopreservation, I think that I cannot tell you many things that you don't know about that. I think that cryopreservation has modified the way that we have done reproductive medicine. Nowadays, it doesn't have any sense to have hyperstimulation in our clinics. This can be avoided. And also the use of cryobank embryos and cryobank oocytes give us another way to do things. Even we are just considering the possibility to move to defer embryo transfer in all patients, because also we can take care of the endometrium and we can analyze properly our embryos. So cryopreservation, I think that you realize how has changed the way that we do things. What about the endometrium? Again, the maternal part, for a long time neglected. We always believed that the window of implantation was there in all of our patients, so we transfer our embryos wherever our embryos were ready. We just give progesterone and we start to care whether the progesterone was given by oral or just parental administration. It's the only thing that we have done in the past. Again, the same thing. We have to consider all the puzzle together. First, it's important to have the visuals. It's important to know about the ultrasound. That's fine. It's important to know in hysteroscopy if we have found a problem in the ultrasound. It's important to have a Doppler if we want to. But the fact that the Doppler is okay, the fact that the ultrasound is okay, doesn't mean that this endometrium is receptive. We have now the transcriptomics, which is the molecular techniques that they are letting us know, informing about this specific function, which is endometrial receptivity. We have also the secretomics, which is to have this information from the endometrial fluid. We have also the endometrial stem cells that they are just giving us the possibility to treat incurable diseases such as Asherman syndrome and atrophic endometrium. And we have just learned about that the uterine cavity is not sterile anymore, and the microbiota of the uterus also exists. But all of these things must be considered in order to improve the possibilities of our patients, and this is what we are in the place nowadays. And also, not only the normalcy, but also synchronization is very important. Timing is crucial for everything, but also for conception. Synchronization, as you will see, is very important, and we have to know not only where is our embryo, but also where is the receptive status of our patients. Regarding to that, as you know, we were for more than 10 years trying to get the signature, the transcriptomic signature of endometrial receptivity, and we just published in 2011 this ERA test. And with this ERA test, we have been able, this is composed by 238 genes, and we are able to give a diagnosis of receptivity or not by analyzing those genes. We are doing this with NGS. It's coupled to a bioinformatic predictor, a classificator, and originally what we were able to really diagnose is whether this endometrium that you obtain can be categorized as pre-receptive and needs 1 or 2 more days of progesterone, receptive, so that's it, you can go ahead like that, or post-receptive, the window already passed. Now with the time, we have learned, we have analyzed more than 20,000 endometrial samples, and we have retrained the whole test, not only for receptivity, but also receptivity and pregnancy. And we are improving much the tool. So we are able just to add timing in order to make a window not only receptive, but what we call AAA receptive, that in which the implantation rate will go for 90%. So within the receptive window, there is subclasses, and this is what we have learned also recently. Altogether, the point here is personalization of the endometrial factor. And we learned that the window of implantation, which we thought that there were 3 days, first of all, is not 3 days, and second, every patient must have a different window. The majority of them, they will have a window of implantation after 5 days of progesterone. But in 30% of your patients, you are going to find a window that will be delayed, or that will be advanced, or even a narrow window. And those patients, they have been the most difficult patients with implantation failure, and this is what this test has been produced, and we have published prospective clinical trials demonstrating that by doing this, you correct the endometrial factor part of the problem. And because of that, we came with this idea of the personalized embryo transfer, which means basically to transfer the embryo in due time, not only when the embryo was ready, but also when the endometrial window of implantation was there. And we learned that you can get your window from progesterone, from 3 days of progesterone up to 7 days of progesterone, and this depends on the patient. And once it's diagnosed in the patient, this stays for at least, we have proved, 4 years, and now we have second generation of children in patients that we transfer in the personalized window of implantation in the first time, and they have the very same pattern now. Again, this is more than 20,000 patients, more than in 54 countries, more than 600 clinics, and we have still this figure. 30% of the cases, the window is displaced. The majority, they need 1 or 2 days, and 12%, they need 1 day less of progesterone. And this is the randomized clinical trial that we have finished this year, and this month. We just closed the recruitment this month that involves 546 patients. This was the result of the interim study that they were presented in ISRM. Those were patients just in the very first appointment. We want to learn if we do not have to wait that they fail 3 cycles before doing the test, if we can do it just at the first, as we do a semen analysis or an AMH. So because of that, we have this randomized clinical trial in which we have fresh embryo transfer, they were blastocyst transfer, they were the criteria that you saw. PGS was not an inclusion, neither an exclusion criteria. So we have one group which is fresh, the other which is deferred embryo transfer. We freeze them all, we transfer them wherever the centers they want to do it. And the third is the personalized embryo transfer, which basically we freeze them all, we do the ERA test, and we transfer the embryo in a personalized embryonic transfer, as mentioned. Just to show you, those are all the centers participating in this RCT. The Bahçeci group is involved in this randomized clinical trial. As mentioned, it's finished this month. We have to wait now 1 year that the babies will be born, because the first objective was basically live birth. That's why we were able to display at the interim study this, because live birth was not possible. And with that, I just want to give you this highlight. What we found was that there was a 25% increase in pregnancy rate in the personalized embryo transfer group compared the fresh and the deferred embryo transfer. This was the only thing that was significant in the interim. The rest, as you see, the percentage were increased, but they were not significant yet. And the ongoing pregnancy also was 55 versus 44 and 43, but this was not significant at this moment. So we will, once we publish the whole paper, we will know about if this will be cost effectiveness in terms of doing the ERA test in the very first appointment. So in conclusion from this part is that the best day for embryo transfer depends on the patient, depends on the uterus of the patient. And this transcriptomic signature is helping us to personalize the situation in your patients, and we know that 25–30% of the patients with recurrent implantation failure of endometrial origin, we can solve the problem by knowing the moment to transfer the embryos. And this is the RCT that is underway. Let me tell you about this, because this is something which we have to think on that. As you know, the bacteria, they are living with us. As you may know, if you are 70 kilograms weight, 1 kilogram of your body weight, they are bacteria, that they are living mainly in your reproductive, in your intestinal tract, but also in your skin. And until now, they were not be able to be analyzed because most of them, the majority of them, they are not culturable. It's only now that we can have access to NGS, to genetic technologies, that they are able to identify those bacteria that we are now at the moment to look for that. So the question that we asked ourselves 6 years ago was, is there a specific endometrial microbiome? And if so, could this endometrial microbiome, an alteration of that, could be affecting implantation rates? So this is the paper that was published in December. This was in American Journal of Obstetrics and Gynecology, and we have a commentary from the editors. And the summary of this paper is as follows. First, this is how we did that. We analyzed this in the endometrial fluid, and we did it with pyrosequencing, using the RNA, analyzing the DNA, and then the bacterial DNA from the ribosomes of the bacteria, that this is a well-known to characterize what is the type of bacteria. By doing this technology, we have three studies. First, we want to know whether endometrial and vaginal microbiota differ or not, whether if we analyze the vagina, we also analyze the uterus or not. And second, to know whether the uterine cavity is sterile. So what we did, as you have here, those are healthy ovum donors, in which we obtain endometrial fluid and vaginal aspiration in the pre-receptive and receptive phase. And the results were, as you see here, that yes, they are very close, but they are not the same. You have these 6 patients that the profile of the microbiome was different in the vagina and in the endometrium. There was normal in one part and completely abnormal in the other. So certainly it's not the same. So the conclusion, I mean, the paper is published, you can go for that, but I just want to highlight. The first conclusion is that the uterine cavity is not sterile, and the endometrial and vaginal microbiomes are different in asymptomatic women. Second, we want to find out whether they were hormonally regulated. So we study what happens in the pre-receptive and receptive phases, and the results were that basically they are not hormonally regulated. We have the same profile in the pre-receptive and receptive endometrium, which is important in order to know how consistent is this, and they will not vary with the menstrual cycle, which is what it used to happen in the endometrium. And third, we have these infertile patients, 35 patients that we did an ERA test, and we obtained the endometrial fluid together with the ERA test, and we let them go. They undergo the IVF process, and we do the embryo transfer, and we obtain the results. And this is the results that you can see here. This is the group. LDM means lactobacillite group and non-lactobacilli group. At the end, the good guys are the lactobacilli. If they are less than 90%, it's considered a dysbiotic endometrium. And then, as you see, in these patients, all of them, they were receptive, but those that they have a dysbiotic microbiota, the results of pregnancy rate, implantation rate, they were just almost half of it, from 70% to 33%, and miscarriage rate goes from 16% from 16 to 60%. So, and this is for you to visualize. The blue is lactobacilli, and this is the graph for the live births, for the miscarriage, and for the non-pregnant. So indeed, this is something to consider, and we are now coupling this test to the ERA test, and we are pursuing now a large prospective study to prove that this is the case. And remember that those were patients even knowing where the window of implantation was. And the idea is, if those patients that they fail implantation and they have an abnormal microbiota, we can replace back the microbiota, adding the lactobacilli that we are already prepared in tampons in the vagina, so it goes through the cervix, and once the microbiota is restored, the patient will be allowed to go back again to try to become pregnant. This is another point that we want to add for that. Therefore, this is the next step on that. Just a few words about stem cells. As you know, the endometrium is a highly regenerative organ. We have been working for a long time trying to find out the endometrial stem cell population, and from this basic work, we decided to move to the clinic, and the clinic was to try to treat those untreatable diseases, which are Asherman syndrome and atrophic endometrium. This paper was published last year in Human Reproduction. This is the phase 1 trial in which what we did is to mobilize endometrial stem cells from the bone marrow, that the phenotype is an endometrial stem cell. We obtained from the same patient, and we introduced through the uterine artery by non-invasive radiology through the niche, which is basically the basalis near the vessels, and we went through this phase 1 with 16 patients, and we got 5 pregnancies. This is the most quoted paper in Human Reproduction this year, and if you come to ESHRE, I will do the opening presentation giving you the details on this paper. But again, shows you that personalizing and going further in the understanding on the problem could solve. And we talk about refractory Asherman syndromes, patients with 4 and 5 hysteroscopies, that we just touch the synechiae, but what we have done with this is to promote the growth of new endometrium. And future reproductive medicine, just a few words, is just to let you know that I think that one of the most important issues for the future, although it will take a long time, is to be able to generate gametes in patients that they do not have it. You know what ovum donation means. You know how hard it is to get this ovum donation for legal reasons, because the patient doesn't want this. Everybody wants to have their own genetic offspring. And, but scientifically, I mean, you know the relevance of the topic. But scientifically, in the animal models, we know that this can be done. And in fact, there has been generated functional sperm and functional eggs from these mouse embryonic stem cells, resulting in healthy and fertile offspring. And there is also the publication of in vitro only generation of artificial gametes in the rodent model. We have published last year in scientific reports this paper, in which, taking advantage of reprogramming, instead of going to the typical reprogramming, which is going back from somatic cells to pluripotent cells and then to direct to gamete, we work on what is called direct reprogramming, taking the cells from the either stromal cells or mesenchymal stem cells and trying to reprogram directly to the place that we want it at the end. It has been reports about doing this to produce hematopoietic projectors, neurons, cardiomyocytes. So we aim to do this in order to build up induced germ cells that they are the progenitors of the gametes. The publication is there. You can see that, scientific reports. And we have this cocktail of 6 factors that we learn from that, from the embryonic development. And by doing this direct reprogramming, we have been able to obtain haploid cells that they have the genetic, epigenetic profile similar like these germ cells. And also, once we take them to the niche, in this case is the testis of the mouse, and they behave like stem cells. They go to the basal membrane. So we have all of these tests up to the xenotransplantation assay. And finally, I just want to leave you with this slide, which is basically that the first revolution was to dissociate reproduction from the sex. And this was the oral contraceptive pills. And this was to prevent unwanted pregnancies. I think that the second revolution nowadays is just to dissociate the sex from the reproduction in order to conceive healthy babies. And the question that I just placed last month in fertility and sterility is, why should patients experience infertility or poor outcomes? Why should patients experience that before using assisted reproductive technologies? There is a nice book coming from Stanford, which name is The End of the Sex, in which the whole thing is about to let you know why, if we go to deliver our baby to a hospital, why we don't go to conceive to our babies in a reproductive medicine clinic, in which we will take care that the baby will not have genetic problems, will not have chromosomal problems, and we can prevent any unwanted outcome for the future. And with that, I just want to thank you for your attention. I just missed the final slides I just want to thank to all the people working with me in iGenomics on that, and also all the clinics worldwide collaborating with us in doing these prospective clinical trials that I hope that will be for the best of our patients. Thank you very much for your attention.
Thank you for your nice presentation. Can we have some question from audience? Do you have any question? Yes.
Thank you for your presentation. My question about your clinical trial about ERA test. When you compare the groups frozen cycle and the study arm ERA test cycle, when you compare the pregnancy rate between the frozen cycle and the ERA test, cycle. What about the pregnancy rates? Because when you include the fresh cycles as control group, and when compare the three groups, I think it may dilute the effect of the real impact. So, because as we know that the implantation rate and the pregnancy rate of frozen cycle is higher than the fresh cycles. So did you compare only the frozen cycle and the ERA test cycle? Thank you.
Well, thank you for your question. No, we compared the three of them. When we start the project, when we start the trial, there was this ongoing discussion of whether this is better the fresh or all frozen. So because we want to prove that we improve the endometrial factor, we have to include the two available situations plus the new one that we have, that we are investigating. Because if we only compare one of them, there will be always somebody asking for the other one. So that's why we have to compare the three of them, and that's why the number of patients is larger. But keep in mind that the embryo part is not analyzed in this RCT. So we are just considering that whatever the embryo has will be similar in all of these three groups, because PGS was not an inclusion, neither an exclusion criteria. We aim to test with that what could be the difference in terms of the endometrial factor in these three parts: fresh, all frozen, and all frozen with personalized embryo transfer directing to the window of implantation.
Şeyi getirir misin çocuklar?
Philip Konings from Belgium. 78, we published a paper, Delayed Onset of Luteal Phase. And you see that in some women you have between the LH peak and the onset of the progesterone 2, 3, 4, 5 days occasionally. So at that moment we didn't understand. When I see at this moment the implantation window, which comes very often too late, I'm just wondering whether this could not be a very easy test in order to decide during the transfer cycle whether to postpone the transfer or not.
What do you mean by easy test?
Sorry?
I do not understand properly your question.
You know, in 78, you have delayed onset. Maybe you are too young for that, because you see you have the LH peak, and then normally you have the progesterone going on. In some women, it's not going on normally, but starting with the delay of 1, 2, 3, 4 days. So this is exactly what you are telling at this moment, and then I am wondering whether just monitoring the LH peak and the basal body temperature of progesterone could not be an easy test in the cycle to decide when to do the fresh transfer.
Thank you. You know, I have tried, all my life I have tried to go one step further. So yes, LH was there, but you know that LH, sometimes you have two peaks of LH, sometimes the LH doesn't work, and sometimes older patients, they have a very, so we always try to go to the target, which is the endometrium. Probably, yes, those are biomarkers. The LH must start this. The elevation of progesterone is also the way that everything, but with this test, what we try is to go to the target, which is the endometrium, and find out whether yes or not. What you said exactly is there are surrogate markers that they can help us, and they have been helping us for decades until now. But for doing this, what I used to do is just even HRT is what we are using, even without LH peak, or if we use natural cycles, give ACG. So we are timing this. So again, this is always the discussion about whether, you know, to my mind, we are going to the target to try to be sure that yes, it's at this time or not. And also this must be reproducible. So in the next month, what we are going to transfer the embryo, those type of, all of these conditions must be completely recreated.
Okay, Engin.
Dr. Simon, I have 3 questions. The first one, for regarding of the genetic carrier screening, do we have to use for routinely or only we use with the special patients like RIF or something else?
Well, you know, I will use it for all my patients. There is no, I mean, I want to prevent this. This 5% occurs in all your patients. And I'm taking this example as this test because this is the one that we have done it. But in the United States, everybody uses their own carrier screening with different type of numbers, but I will use in all of them.
Okay, the second one, for the producing of artificial gametes at the lab, at least 15 or more than 15 years, we are on the same point, according to my knowledge. There is no improvement. Could we say for the next 10 years, can we go improvement for the producing artificial gametes, maybe sperm or oocyte? Do you believe that one?
Yeah, it's difficult to forecast, but what I can tell you that those science papers and scientific reports papers, they came in the last 5 years. And it's very difficult in the laboratory to do it. At the end, we have to use kind of a xenograft. We have to use, the niche is crucial to do that. So I don't know how, but I can tell you that the efforts are worldwide, and sooner or later we will get something like that. It will take a long time. This is a long-term project. The other ones, they are shorter.
For the last one, for the concerning the ERA test, as my knowledge, we are just using as a patent 240 genes in there, right? Nearly 240, right?
238.
38, 40. Only we can say we are just measuring that genes, and we say this is receptive or not. Do you believe it is enough for the endometrium? Because endometrium is like the puzzle. Can we say just measuring that part of the genes, is it enough for the see the whole picture?
Yes, I mean, this is the work for more than 10 years, and this we create this prediction as onion sheets, in which you have a core of something like 60 genes that they are crucial, and the others, they are helping us to inform about that and to predict that. At the end, you want a good predictor. It's like for a breast cancer, but yes, with these numbers, it's enough. Maybe we will add something else in the future as soon as we are moving, but for instance, to have the microbiome, you don't need, we talk about different functions, but with the same tissue or with the same endometrial fluid, because now we are moving to the non-invasive era. The whole thing is to repeat that in the endometrial fluid, which is close by. The idea is with the patient, they don't have to be bothered just once, and with these type of samples, with RNA, we can do this prediction. With the DNA, we can do the microbiome and whatever it comes in the future.
Thank you.
Okay. She's my nurse.
So hello, I'm Nagihan. I'm working Bahçeci and I'm so happy there. So anyway, I have a question. We can do the ERA test for the natural cyclist patient, like no drugs, anything. We don't know the, do you understand me?
Sure.
Okay.
You do in natural cycles, you mean?
Yes.
Yes, you can do it, but what I suggest you is to give a ACG at the time that you think is the LH. I mean, if you have a 17 millimeters follicle, then do the ACG, so you time this, and it will be, I mean, you can repeat that in the cycle that you are going to transfer the embryo. Mm-hmm. So the results will be, you can extrapolate this. What it bothers me about natural cycles is that sometimes the variability of the LH peak, even in blood, even and we have experts here about LH in natural cycles, we want to be consistent. So my first suggestion will be doing an HRT cycle. It's so simple. With the menstruation, give 6 milligrams of estradiol valerate, 1 week, an ultrasound, decent endometrial lining, 5 days of progesterone, and that's it. If you want to do it in natural cycle, just give an ACG at the moment that she's ready to go.
Okay, thank you. And the second one is the progestin time is important for ERA test. Like we are doing the intramuscular progestin or the oral way. or the vaginal way. And for example, the patients using the 5 a.m. and then the error test is important, like the time, really important, or we can do anywhere.
Excuse me, can you repeat again?
I mean, progestin time. For example, the patients using progestin, IM way, and then she's doing, for example, the 5 p.m., okay? And then the error test necessary is the time, progestin time.
You know, the most important thing is the time where progesterone administration starts, either endogenous or exogenous. This is what is really producing the time, the system start to work after that. So if you are able to time that, you don't need to be precise by the hour or 3 or 4 hours. But we have done these studies in many clinics throughout the world. And what you believe that is the same for all of us, which is HRT and 5 days of progesterone, we have found out that some patients, they transfer those embryos at 4 days, and some doctors, they do it at day 7. And they believe that they are doing the same thing, because even they are confused about what we call that the progesterone, the day of progesterone administration. It's not the same like gonadotrophins. If you give progesterone now is not day 1. Day 1 will be tomorrow at this moment. So my suggestion is just go 5 days after you start your progesterone, and you will have these 5 days, 120 hours, and with that we can reach the conclusions. We will give you an approximation. We always give the approximation plus minus 3 hours, and with this range you can do your embryo transfer.
Thank you for your answer.
Thank you.
Okay.
Dr. Mustafa Bahçeci from Bahçeci, Fulya. Thank you for your excellent presentation. I have 2 questions. First, in frozen embryo cycles for endometrial preparation, we usually use antibiotics. Do you recommend adding lactobacillus, I mean something like that, microbiota after antibiotic to maintain vaginal flora? First question. And the second question, in adenomyosis group, usually error test doesn't change like others, but we still see more miscarriage, implantation failures in adenomyotic groups. I want to take your recommendations about this issue. Thank you.
Thank you. Adenomyosis, really, we don't know what is going on. To be honest, when you see this big adenomyosis with this big endometrial cyst inside, sorry, inside of the endometrium, we don't know how it affects endometrial receptivity, or it's later on in the decidualization that affects the pregnancy and the miscarriage. To be honest, what we do is just to give GnRH agonist and to wait until those cysts, they improve. With the adenomyosis, we really don't know what is going on. The endometrium is misplaced and is growing at the wrong direction, and we don't know really how it affects the whole thing, but we know that this is not good. Your first question, you mentioned that you are using antagonists for the HRT. Antibiotics. I will not suggest you to do antibiotics, because by doing this, we are just changing the whole thing inside, and we don't know how it will really affect that. I suggest to know what is there and then to treat it. And keep in mind that we talk about microbiosis. You can treat it with probiotics, just enhancing what you need for you to have a beneficial effect. Giving antibiotic can really produce, that really you can have a vaginosis because you are giving antibiotics elsewhere. So this is just the clear example of that. And for HRT, you don't need to give antagonist, agonist, just so straightforward. It's simple, 12 days of preparation, and that's it.
Is there any question? Okay. Arkanda. İşitmiyoruz Nadir.
Hello, yeah. Nadir Subay from UK. I'd like to ask you a hypothetical question, if you don't mind. You mentioned about artificial gametes and future of IVF. Let's say we came to an ideal situation that we can make up gametes in the laboratory and we can quantify their quality, genetic status and everything, and we know that they are of high quality. How much these gametes, when they are inseminated or fertilized, will be vulnerable to post-mitotic errors that will cause implantation failure?
Your question is really hypothetical because I have no idea how sensible will be for that. But if we elucubrate, and this is also in the book that I mentioned to you about the end of the sex, in an ideal world, if we can have an unlimited source of gametes, imagine what this could be. To have from a patient which is 45, we can get the oocyte from them, we can produce as many embryos as we can, and then we can analyze them all and know whether they are chromosomally normal or not. Again, I'm just being completely science fiction. But I am aware of the big hurdles in the way to get those gametes really going, because this is not just a heart cell that this is beating or a muscle cell. It's going to produce a baby. So first, we have to have bona fide gametes. And second, we have to produce embryos with these gametes. The only country in the world to do that in a legal environment is United Kingdom. So if it comes the time, this will be the only way to prove that those embryos will be normal, abnormal, and not only about what you mentioned, but also the epigenetics. We have no idea how it's going to work. But I mean, let's start with the first step, because you know, maybe we will not achieve that, but at least we have to try. Because organ donation affects at half of the patients, at least in the United States and also in Spain. So half of 50% of patients in reproductive medicine in some places, they need the gametes from other couples, and we know how difficult is that.
Thank you.
Okay. We thank you, Professor Simon, for his nice presentation. We don't get any break. We start next session as soon as possible. Thank you very much.
Thank you.
Dear ladies and gentlemen, welcome to the first session of this beautiful meeting. The topic of this session is contemporary endocrinology versus genetics. Will the later replace the former? So the first speaker on this issue will be Professor Hüman Fatemi. Is he here? Okay. I would briefly try to introduce Professor Fatemi to you, but you might all know about him very well. After an outstanding career in Brussels University, Professor Fatemi had moved to Abu Dhabi to establish IVI Middle East, and now he's the director of IVI Middle East in Abu Dhabi. And we are very happy to see him here again with us. So thank you for coming. Please.
It's a pleasure to be here. I would also like to thank the organizing committee of inviting me. There are only two major problems that were generated here. One is the topic which was given to me. It's a very challenging topic. The second is I have to speak after Carlos Simon. He is such an excellent speaker, so it puts a threshold very, very high. So I have to do my best now. Now, when we speak about endocrinology and genetics, I think we all agree that it is very important to have a receptive endometrium. If you have an embryo which is of excellent quality, and you have an endometrium, as Professor Simon mentioned previously, which is not receptive, the patient will not get pregnant. A successful pregnancy is a pregnancy where we are having a receptive endometrium and a genetically normal embryo. We also know that all these hormones which are being produced within the ovary, they have a direct impact on the endometrium. If you have one follicle, that follicle produces a certain amount of hormones, and those hormones, once they go to the systemic circulation, where do they land? They will be landing in the endometrium. And we have neglected that once we start stimulating the patients, we completely change the endocrine environment. As mentioned previously, there is something which is very vague to us. We define it as a window of implantation, but honestly, the more I know about it, the less I understand it. We said the window of implantation is a window of 4 to 5 days, but please be careful. We're speaking here about a natural cycle. It would be naive to think that a natural cycle is comparable with a stimulated cycle. From Nick Macklon's group, many publications came out demonstrating clearly that all these cytokine profiles which are responsible for the implantation change significantly. You cannot compare a stimulated cycle with a natural cycle. On the other side, we need to stimulate because we need oocytes. If you take a look at all these interleucin cytokines which are important and you compare the natural cycle with a stimulated cycle, immediately you recognize that there are significant differences. Now, we try to simplify our life. What did we do? We said we're going to do a scan. We're going to look at the endometrium. We're going to measure and say it is 9 millimeters and I'm happy. But is it really that simple? Can we measure the endometrium and say that endometrium is receptive or that endometrium is not receptive? I think not. That is too simplistic. There is much more going behind, as Professor Simon mentioned previously. And we also know that once we stimulate the patient, the endometrium is advanced. Once the endometrium is advanced, if it's too advanced, the pregnancy rates drop. Now, when we speak about stimulation, endocrinology, and genetics, we need to stimulate the patient, because if we don't stimulate the patient, what happens? We have less number of eggs. On the other side, once we stimulate the patient, we generate, again, an issue here. We are generating endometrial advancement. All the endometria which are being stimulated are advanced. However, not everyone is advanced on the same pattern. Some are advanced 1 or 2 days, but some are advanced by more than 2 days. Now, the first question you would ask, okay, why are some patients advanced 1 or 2 days and the other patients advanced by more than 2 days? And what impact does it have if it's advanced by more than 2 days? It's very simple. If you have an endometrium which is advanced by more than 2 days, you simply have no pregnancies. Very simple. Now, how do we solve the issue? So we stimulate the patients, and as was mentioned previously, the endometrium of an endometrium which is not being stimulated is much more receptive than endometrium which is being stimulated. Logic, because we change completely the endocrine profile. If you take a look at this study, meta-analysis looking into the pregnancy rates, comparing fresh and frozen cycles, obviously the frozen cycles are doing much better. Why? Because we have not stimulated that endometrium. It's a more natural environment. It's not a hostile environment that we generate like when we stimulate the patients. I don't know if you know that study. That's a beautiful study published by Anya Pingbohn's group. Henningsen is the first author who is doing her PhD on the topic. You know that if there is a lady who is expecting her first child, that first child has a certain body weight. If that patient is having a second child, the body weight of the second child is higher because the blood supply to the uterus is better. So if you have a spontaneous conception, first child, and you have a spontaneous conception, second child, the body weight of the second child goes up. However, if you have the first child IVF, the second child spontaneous conception, there is also a slight increase. Not significant, but slight increase. But on the other side, if you have the first child having a spontaneous conception, and the second child, an IVF, the birth weight of the babies is going down. You would expect the second child to be heavier because there is a better blood supply, but it seems not to be. Is it maybe because of endometrial changes, because we stimulate? You might argue maybe it's because of the IVF. It's not because of IVF. Because if your first child is an IVF, fresh IVF child, and the second child is a frozen embryo, look what's happening. Huge increase in birth weight. And if your first child is frozen, the second child fresh, there is again a drop. So this slide is clearly demonstrating when we stimulate the patients, we have an impact on the endometrium. That has been proven on many, many occasions. And personally, I think that the natural endometrium is still the most receptive endometrium if a patient is having a natural cycle, obviously. Here we compared a natural cycle based on LH in the blood as to a cycle which was AC-induced, and in these frozen cycles, with a complete natural LH rise, the pregnancy rate was significantly higher. Now you would ask the question, how does it come that there are some patients who have endometrial advancement of 1 or 2 days, and there are some patients who have endometrial advancement of more than 2 days? Because once you pass these 2 days, the pregnancy rates drop. Now, endometrium is very complex, but what we know that all of that is controlled by steroids. So if we have the feasibility to control the steroids, then maybe we can control the receptivity of the endometrium. Steroids, specifically, what we are looking at is the progesterone. Because once we stimulate the patient, we know estradiol increases. We generate multiple follicular growth, estradiol goes up. Now, steroidogenesis, production of steroids, goes through these lines. We have delta 4 and delta 5 pathway, where through conversion of cholesterol, different enzymes which are responsible, and here you have the end product estradiol. If you go through the other path, you have the end product progesterone. Now, once you stimulate the patients, you push and push and push the follicles, you generate multiple follicular growth. Towards the end of the follicular phase, what is happening? Your steroids go up. Once the steroids go up, what do? We continue pushing the follicles. It's not that we stop the stimulation, because we are stimulating the patients until the day of final oocyte maturation, the day of trigger. But once you put too much pressure on these enzymes, at some point, they cannot produce more estradiol. They are working on the maximum. So what do they do once they are working at the maximum? Instead of producing estradiol, they will start producing progesterone. And that progesterone seems to have an impact on the endometrial advancement that you have seen. So we stimulate the patients because we need oocytes, and we stimulate too much, and we reduce the endometrial receptivity because we put too much pressure on the follicles, generating what we call a premature progesterone rise. Now, a progesterone rise in the follicular phase is a natural phenomenon. It happens in nature. Once the follicles become bigger, there is an increase in production of progesterone, but that remains limited. You always remain below a certain level. But what we do, once we stimulate, progesterone goes up and up and up, and it seems once progesterone goes above a certain level, that the pregnancy rates crash down. Now, you can argue about the level, is it 1.3, 1.2, or 1.5? There are many inter-assay variations, and so on, and so on, and so on. But everyone agrees that actually progesterone rise has a negative impact on endometrial receptivity. One question that we are always being asked, how many eggs do I need to have a successful pregnancy? I'm 100% sure if I start asking each one of you, what would be your response, we would hear many different numbers. But the correct way to ask this question would be, how many eggs at any given age with keeping the endometrium receptive would I need to be successful? This publication comes from Ernesto Bosch, where he looked in more than 4,000 cycles into number of eggs, but he kept the progesterone values in consideration. You see, if progesterone goes above 1.5 or below 1.5, above 1.5, more eggs, pregnancy rates drop. But more eggs, more pregnancies if progesterone remains low. It means if you push the follicles, you are not jeopardizing the outcome, you are increasing the outcome, but as long as you maintain having a receptive endometrium. Because at some point the idea was, with the endocrinology, with stimulating the patients, we generate more abnormal oocytes. Especially the group of Gita Nargund, Bart Fauser, they came out with the concept of mild stimulation because they were mentioning pushing the follicles will generate more chromosomally abnormal oocytes. But is this the truth? If that would be the truth, why do we see a further increase of the pregnancies? It seems the more oocytes we have, the higher is the chance, as long as we keep the endometrium receptive. That is what this slide is telling me. You could tell me I'm not convinced yet. Now, there are two publications. One was done with one of my PhD students, Inge van Varenberg. The other was done from EV by Labarta. Both we looked at the same thing, on different days, but at the same thing. We stratified the patients in different categories. Patients with low progesterone being defined as less than 0.9 nanogram per ml. Patients with a medium progesterone being defined as 1 to 1.5 nanogram per ml. And patients with more than 1.5 nanogram per ml. And we did gene expression of the endometrium. And guess what? There were significant differences once progesterone goes above a certain level. Again, you might argue about the level, is it 1.5, 1.6, 1.4? I don't know. Most probably there are individual variations. But we see clearly there are significant differences. But why does progesterone go up? We have seen previously, most probably because we are pushing too hard. If you take a look to this old publication, by now almost 20 years old, you see that the primary cause is high estradiol and high number of oocytes. So the more eggs we have, the higher the estradiol value, the higher is the risk of having a high progesterone. With Dimitra Kirou, one of my other PhD students, we looked and generated this graph to see, is it feasible to anticipate a premature progesterone rise and reduce the pressure on the follicles by maintaining the endometrium receptive? And the answer was yes. In a REC FSH antagonist cycle, if you reach these values, you have the feasibility to reduce the pressure on the follicles and to reduce the progesterone production without having any impact on the number of oocytes retrieved. To demonstrate that this idea is correct, we came out with a study that we published a couple of months ago. When we start stimulating a patient, we administer every day FSH, FSH, FSH, FSH. We continue doing so even though we have passed the threshold until the patient has reached the point of final oocyte maturation. We don't stop. We continue until we trigger. That's what we do. On the other side, if you would administer a long-acting FSH, choline alpha, what it does, it's doing an automatic step down. It pushes the follicles, and towards the end, it reduces the pressure on the follicles. So if our theory would be correct, that the cause of having less pregnancies and high progesterone with high responders because we have many eggs would be that what we would expect is those patients who reduce the pressure on the follicles towards the end of the follicular phase should have a more receptive endometrium by having lower progesterone levels. And we looked into that and we published that. Barbara Lawrence, my colleague in Abu Dhabi, is the first author in that paper in Human Reproduction. What we did, we said, look, if you use daily FSH or you use long-acting FSH with daily FSH, day 8, day 9, day 10, and so on, the prevalence of high progesterone is exactly the same, no difference. However, if you look at those patients who were ready on day 8 in both categories, but one group you push, the other group you do automated step down. What would be the difference in progesterone? The difference is huge, as you can see. Huge. Why? Because the pressure was taken away from those follicles. Now you might argue, yes, but did you look into the number of eggs and so on and so on? Of course we did. We stratified in different number of oocytes, and we have seen that even if you have extreme high responders, but you do this step-down protocol, you continue having your endometrium receptive. Now, this is an endocrine paper we just published 6 months ago. If you're coming to ESHRE, we're going to have a presentation on the pregnancy rates, and I can tell you they are significantly different. Now, endometrium is one factor when we stimulate the patients. We know that an embryo must be good before it's implanting. Did you know that there is a crosstalk between an embryo and the endometrium? A bad embryo is giving a wrong signal. A good embryo is giving a good signal. There is a crosstalk between these two. If you have a chromosomally normal embryo, good quality embryo, it's communicating with the endometrium and it's being absorbed by endometrium. If you have a chromosomally abnormal, low quality embryo, you see nothing is happening. Now this is a movie. I don't know if you can click the button to play the movie. I don't have anything here. Yes. So if you take a look here, that embryo is approaching the endometrium, it's communicating with the endometrium, and at some point it's being accepted. So what's happening, the endometrium is surrounding the embryo and the embryo is implanting. This is a correct communication between embryo and endometrium. Now, if you have several embryos, because I remember 15, 20 years back, what we were doing, 3, 4, 5 embryos transfer, one of them will implant. That's the wrong concept. Because if you put too many embryos, many of them abnormal, and maybe one of them normal, the abnormal ones will give a bad signal to the endometrium. And that would reduce also the implantation of the good ones by 27%. That was published by Rainer Fenning, I think 6 months ago, recent paper. So it's important that we select the embryos very critically and put them back in a receptive endometrium. Now you could argue, yes, but how can we select that embryo? You could say, I have a good embryologist, I have a good lab, we have all these fancy techniques of embryodynamics and so on and so on. I can tell you, no. The most beautiful blastocyst is a trisomy 21 blastocyst. Is it normal? No. And we know that the prevalence of abnormal oocytes is always present. You always have abnormal oocytes. Are you 22 years or 42 years? You always have them. But the prevalence is much higher once you become older. And the prevalence of having no transfer, once you do a chromosomal screening of the oocytes, also increases with age. And it's a recent paper, FNS, you see that there is a direct link between age and chromosomal information of the embryos. Could you please click the button again? Now, this is an embryo which I would say looks like not a bad embryo. It goes from 2 cells to 4 cells, 8 cells, compacting, blastocyst, hatching. Actually, not a very bad embryo, which you would say on day 5, I'm going to transfer that embryo. But I have to disappoint you. We did not transfer that embryo because that embryo was severely abnormal. And if you take, could you click again, please? If you take to that embryo, that's not a nice embryo. Very slow, a lot of fragmentation, bad division pattern. You would not transfer that embryo. It's a normal embryo, and she got pregnant with that embryo. So can we simplify and say, look, we transferred the embryo based on its morphokinetics? I don't think so. And we know that doing chromosomal screening of the embryos is becoming better and better, and our results are increasing and increasing. This is, I just took at random a paper which was published 2 years ago. Look, 80% versus 40% per transfer. A huge difference. Do we still have to negotiate whether we have to screen the embryos prior transfer? I think that time has passed. There are many studies looking into the outcome with or without PGS, and the results are pointing towards the same issue. Even though, if you take an elderly woman who is 42 years and compare her with a 35-year-old, the pregnancy rates will be the same if you test it, and the miscarriage rates in all age categories is around 7 to 8%. You significantly also reduce your miscarriage rate. Are there differences between inner cell mass trophicoderm that has to be studied? Up to now, studies have shown, yes, it's reliable. Now, you would come and argue about mosaicism. I fully agree with you. It's an issue that we have, but if you have an embryo on day 3, which has 8 cells, it might be that some of those cells are normal, and some of those cells are abnormal. But why should you do the biopsy on day 3 to be wrong, taking maybe the wrong blastomere? On the other side, if you do a biopsy on day 3 and you compare it with day 5, you significantly reduce your pregnancy rate because you damage the embryo. There are many studies having looked into that. So doing a biopsy on day 3 is past. Not only because of mosaicism, also because, as you see here in another study, you reduce significantly your implantation rate. Coming to the point, when we stimulate, we change the endocrine profile, we generate more abnormal eggs. That is the past. I was 3 days ago in China on a lecture tour, and the physicians were presenting these old data that we had from 10 years ago. I told them this is the past. Today we know if you stimulate, you do not generate more abnormal eggs. The percentage of euploidy increases significantly. This is from Munet's group. There is from Filippo Ubaldi's group. This paper is in press now, 2017, new paper. There are many, many data coming out confirming the same again and again and again. This is from Michael Tucker's group from the States. Doyle is the first author. The more eggs you have, the higher is the chance of having 1 baby, 2 babies, or 3 babies. This is at a young age, this is at the older age. You can count how many eggs do I need to have 1, 2, or 3 children. And also we have published the same. There's a human reproduction paper we published a couple of years ago. The more eggs you have, the higher is your pregnancy and cumulative pregnancy rate. So by stimulating the women, what we do, we generate a less receptive endometrium. But that is in our hand. But I think what we see here, we do not generate more abnormal eggs. I think, Mr. Chairman, we can conclude that what we have seen, once we stimulate the patient, we change the endometrial environment. We have seen that the major change is happening because progesterone increases. That progesterone is directly having an impact on the endometrium. The etiology of it is FSH, too much pressure, high estradiol, and 2 big follicles and more oocytes. When we speak about personalized treatment, that is what I understand under personalized treatment, to adjust the stimulation according to the requirement of every patient. We have seen once you reduce the pressure on the follicles, that the progesterone remains low. And today, the most objective way, I'm not going to go into detail on genetics, to evaluate an embryo is performing a chromosomal screening. And what we have seen from Ubaldi's group, from Munet's group, our data, stimulation seems not to have an impact on chromosomal information of the oocytes. Many oocytes of human beings are abnormal. So this is why you need to have many, many oocytes. The older the patients are, the more oocytes you would require to have at the end 1 or 2 normal embryos. And I think it's too simplistic to say, based on morphokinetics, we select the genetically normal embryo. I think in the next couple of years, we will not transfer any embryo without testing it. Thank you very much for your attention.
Thank you very much. We will take questions after the second lecture. Thank you.
We heard the clinician's view. Now we'll take the genetical view. from Dr. David Blesso from Spain and Valencia University. He's also the head of the developmental department of the iGenomics. We're very happy to see him here.
Thank you very much for the presentation. I want to thank to the organizers the invitation to give this talk. At the beginning, I was worried because I know nothing about endocrinology, so I couldn't tell you many things that you already don't know. But when I was considering giving this talk, I remember that I have faced more or less similar case when I was working in cancer genetics. This is the Spanish National Cancer Research Center that was founded in 1988 in Madrid. And the first director of the center was Mariano Barbazi, who came from the USA to direct the center. And I'm telling this you because this was a large bid by the Spanish government to put a very good research in cancer in Spain. So the research that was being doing there was the top rate. And I moved there in 2002 at a lab of the molecular cytogenetics. And at that time, I saw in cancer there were being a discussion about pathologists that at that time were doing the analysis of immunohistochemistry of tumors embedded in paraffin. They were doing microscopy to see the histology of the tumors, to classify samples, immunohistochemistry. And meanwhile, there we were the molecular biologists doing microarrays in order to establish copy number alterations, gene expression of the genes that there were in those tumors. And we have this discussion regarding with that we needed at that time DNA, fresh DNA extracted from the samples, while the pathologists wanted the tumor get fixed in paraffin embedded in paraffin. And in the end, there was these two ways of trying to classify the tumors, and this is an example of a squamous cell carcinoma in which the pathologists were looking at the histology of the tumors in the different stages in order to classify the status of this tumor, while the molecular biologists were looking at different genes that were involved in the evolution of the tumor, starting from genomic instability, dysregulation of the telomerase, losing of tumor suppressor genes, activation of tumor-inducing genes. And in the end, we were looking at different things. Pathologists were looking at the phenotype of the tumors, and we were looking at the genotypes of the tumor. And the phenotypes in the end is the expression of the phenotype is the expression of the genotype, and that is affected by the environment. The environment in which that phenotype is present. And mainly in the phenotype, you are looking at basically the proteins. You have variation in the protein function and variation in the expression of the proteins. And these variations can come from genetic variation that affects mostly to the sequence, but also affects genetic variation to another components of a pathway in which that protein is affected, modifying the activation of the protein, the degradation of the protein folding. But there are also other parts of the pathways that are affected by genetic variation, that is the promoter sequences that affected the gene expression, or there can be altered gene copy number. And these are some things that we have already seen today, like At the carrier screening test, we are looking for sequence variation, and with gene expression arrays, we are looking at gene expression. With the analysis of the embryo, we are looking at copy number alterations. On the other side, there are environmental changes that can affect two different parts of this scheme. Other components that are affected by the environment in which the patient is involved, regulating how the function of the proteins, transcription factors that are responding to, for example, different drugs, will condition the gene expression of the proteins and the amount of the proteins that is expressed. And also the environment will make epigenetic difference that can create different phenotypes. An extreme example of this is what happened with monozygotic twins that has been exposed to different ambients. And what has been shown is that you can identify differences, epigenetic differences, that in the end make that those two twins behave differently in front of the same environment, for example, a drug. And this kind of a study has led to identification of genes that can be related to some diseases or some conditions. So how ended this discussion between pathologists and molecular biologists regarding the cancer? This was in 2004. There was a classification for lung tumors, and after several years of getting more knowledge on them, they give this 2015 World Health Organization classification on lung tumors, and I am showing you one of the recommendations they give. Due to the advances in lung cancer genetics and therapy, they're recommending a new emphasis on genetic studies, in particular the integration of molecular testing to help to personalize treatment strategies. And this is what I think is one of the most important parts of the genetic analysis. Going back to the endocrinology, you all know the pituitary, hypothalamus, pituitary, gonad axis hormones, but those hormones are composed of several genes. They are heterodimers that are composed for two proteins, which are encoded for two different genes. This gene is present in all of the hormones, and each of the genes, you can identify several variants that are present in the general population. Here, you will find the number of variants that has been identified for this alpha unit of the chorionic gonadotropin, 114 different variants. In the database ClinVar, you can find that they have identified 7 out of 11 different variants that are pathogenic. So that means that in the population you can find variants that are pathogenic and are creating a protein that is not properly functional in the patient. You can see the same for the luteinizing hormone. Large number of variants, in this case 455 different variants has been identified. 9 out of 12 are clearly pathogenic. The same for the follicle stimulating hormone, 96 different variants, and 50 out of 33 different variants are pathogenic. So in any of these genes, you can find variants in the populations that are pathogenic and will compromise the function of the protein. But you have also other proteins that are related, other hormones that are related to these ones, like chorionic gonadotropin, also have pathogenic variants. And thyroid-stimulating hormone that also have the pathogenic variants. And on top of this, you still have the receptors for all these hormones that, again, will have variants. Some of them can be pathogenic, classified as pathogenic. And here, there is an example of how to use this genetic background. There is a the title of this paper, a combined assessment of polymorphisms in the LHCH and FSH receptor genes that predicts the chance of pregnancy after in vitro fertilization. They are studying two variants that are present in the population, and they say that the chance of pregnancy is larger with one variant or the other. The implication of these studies is that if some of these variants are recognized as biomarkers for chance of pregnancy, you can apply a more individualized treatment to these patients, just looking at which are the variants that the patients have. Then I wanted to know how many tests you can find in endocrinology, and I look at one of the companies that are providing this kind of test. This is Quest Diagnostics. I have nothing to do with this company. I didn't know this company, but I just wanted to try to understand how many genetic tests were around in endocrinology. This is the catalog of this company for endocrinology tests, and they have many different studies for different kind of hormones, but there are a set of genetic studies which involve all these different tests. And apart from all these different tests, in the whole catalog they already have plenty of genetic tests. These two slides are the whole catalog of tests for this company. So we already have plenty of genetics tests that are done in endocrinology. And to summarize a bit this talk, this is the introduction of a paper that is a bit old. It's 2012, but it says more or less the basic of what is the genetic point of view. As an endocrinologist, they have to have a good understanding of the genetics of the endocrine disease, because that will help for the management of the patient, but also for a personalized surveillance of the patients, and also for the relatives that can be affected by the same conditions because they have something inherited. And also the analysis of the genetic part of the patient for those couples that are at risk may help to those couples to take reproductive decisions. So going back to the question, if will the genetics replace the current way of making endocrinology, the clinical way, I was thinking perhaps the people under 40 years old that are in this room, they are the future of the field. They are the most entrepreneurs and the more taking risk people, and they will say, yes, in a few years, the genetic concision will direct the diagnosis of the endocrinology diagnosis, yes. The people that are between 40 and 60 years old, we are more experienced and we can be more cautious, and probably we will say, I'm not sure, it will have to be evaluated on a base-by-base cases. And the people that is over 60 years old, of course, they have the wisdom, and they have seen many things along during their life, and probably they will say, I only know that I know nothing, and I don't know how it's going to evolve this field. And that's all for my part. Thank you very much for your attention.
Dr. Blesa, now we can take questions or comments from the audience.
If there are no questions, can I take the privilege to ask the first question to Professor Fatemi? Okay. In this Danish study, in this Danish study with the birth weights of the babies born, you ascribe these findings to the endometrial stimulation. But can it be the ovarian stimulation itself as a effect, epigenetic effects on the babies?
Absolutely. So there are some thoughts that vitrifying, freezing the oocytes, so the embryos, have an impact on epigenetic levels of the embryos. Whether that is the reason, I think the only way to look at it is if they compare first baby fresh, second baby frozen, or first baby frozen, second baby fresh, and compare the discrepancy between these two groups. So I've asked Anya Pingborn, who did this study, to look into that. Most probably that would answer the question, but you're absolutely right. There are many studies looking into epigenetic changes through vitrification. It could be both-sided. It could be that you have an impact on the endometrium, but that you also have most probably some epigenetic changes. And also I think, it's too premature, because very often what we do now, there are many clinics worldwide, they go to freeze-all strategy because the results are simply better, but we fail to have long-term studies. I mean, we know it is safe, a couple of years, yes, but will we increase somehow in 20, 30, 40 years some diseases that we're not aware of? So this is why I think it's too premature to say we should go and freeze all for everyone.
And one more question. In your study with the long-acting FSH, as you know, the ensure and engage pregnancy rates are not superior in the recombinant long-acting arm. So is it an error? I mean, or since the
problem is, thank you for that question, that's a very good question. When these data were published from Engage and Ensure, no one looked into subgroups of patients with high and low progesterone. There is a paper by George Griesinger, but they put everyone in one basket and draw conclusions. But what we did, and what we're going to present now at ESHRE this year in Geneva, we stratified the patients of low and high progesterone and look into the outcome, and there is a difference. There is a significant difference. The mistake was, and I have to tell you, I did the same mistake, because I had an abstract at ESHRE in 2012 looking into the same data. I published them, but I was wrong. The mistake I did, we looked into Elonva plus daily FSH and Elonva alone. And we said, look, with Elonva, you don't have less progesterone. But here, the bias is that you look also to daily FSH. But we knew that 33% of patients required only one injection. So what we did, we only took that 33%. And when we retrieved this data, it was amazing to see. So I was happy that the theory came out as correct.
Thank you so much.
Here's a question.
Can we use estrogen plus progesterone level rather than looking at the progesterone at pre-ACG? Because you say it's the usual biological outcome of estrogen level. So can we use in our clinics this ratio rather than looking at the progesterone?
You could do that, but I think you need to put follicular dynamics also into account. So imagine if you're having a certain level of estradiol and your follicles are still too small, let's say 10, 11, 12 millimeters, and you would reduce the dose, the follicles would go to regression. So most probably you need not only to put estradiol and progesterone into account, but also follicular dynamics. Now it becomes more complex because the progesterone in the systemic circulation is not only coming from the ovaries. 20 to 30% of the progesterone in the systemic circulation comes from adrenal cortex. So also that plays a role. This is why what we always do, we measure progesterone prior starting stimulating the patient. If you have a patient who has a period on day 2 or 3, and the progesterone is 0.9 nanogram per ml, or a patient who has a progesterone of 0.1 or 2 nanogram per ml, these are huge differences. Because that patient who is 0.9 will go much faster to 1.5 than that patient who has 0.1. So this, and it's beautiful to observe. So if you follow up the progesterone, you can fine-tune it very easily. Estradiol goes up, after 5-6 days, progesterone goes up. And at some point, once you reach a certain level of estradiol, follicular size, then you need to do the step down, you need to reduce the pressure. So answering your question, only estradiol-progesterone correlation could be that some calculation can be made, but I think you need to be more critical and more individualized because not all the progesterone is coming from the ovary. So I would also put the beginning progesterone before you start stimulating and also put the follicular dynamics into account. And I would never reduce the dose before the follicles have reached 13, 14, because if you do that, the follicles will go into regression and the hormones will drop.
Thank you.
Dr. Fatemi, how about the progesterone level at the beginning of the cycle, day 2 or 3? Is it important like the other one?
Yeah, that's absolutely important because, as I mentioned, you know, imagine a patient who starts with 0.9 on day 2 of the cycle has a much higher risk of going to 1.5 very fast than the one who has 0.1. So if you say, I'm going to go for a fresh and I don't want to freeze for that patient, I would do everything to bring down the progesterone before I'm starting that patient. Obviously, you have done a scan, there is no corpus luteum, there is no cyst, nothing is there, but still the patient's having 0.9. So most probably that is coming partially from adrenal cortex. If you want to suppress the adrenal cortex, you need to go suppressing your ACTH. You can suppress your ACTH through administration of 1 dose of prednisolone, for example. Then your ACTH would go down, your progesterone goes down, it will go down to 0.5, 0.6, and then you start stimulating the patient. In the next couple of days, it will go up again, but by then, you have reached the point that you want to trigger final oocyte maturation. But you know, I really don't know if it's really the progesterone which is the bad guy. Because do you know what is the difference if you measure progesterone in the morning and in the evening on the same day? 50%.
Yeah.
Do you know what is the difference between different assays? 50%. So what objectivity do we have, you know, when we say 0.9, 0.8? But somehow I think you agree that there is a problem if progesterone goes up. What I think is progesterone is not good, for sure it's not good. But I think all studies have shown if you give FSH, FSH generates LH receptors. So if you give too much FSH, especially at the end, you generate too many LH receptors. Now, when you trigger, what happens? You cover all these LH receptors. So most probably, it's the trigger which is the harmful thing, and not this variation of progesterone that we have. If you have too many LH receptors because you have given too much FSH, what will happen? Your progesterone will shoot up very fast because you have too many LH receptors. And if you have, for example, done a step down that you didn't put too many LH receptors, most probably it would be different that your LH goes up. I think a beautiful study would be if you have an antagonist cycle with high progesterone, low progesterone, that you trigger these two groups with 2 different trigger shots. One with ACG, which is very potent, should go up, high progesterone, low progesterone, or with agonist, which goes more physiologic. Could be that you're counteracting the high progesterone by giving an agonist, and then you give a late luteal phase support with ACG. But that's a concept that should be done in the near future.
The second one, you said as the very strong sentence to me, corifoliotropin is the better than the other ones for the recording of the progesterone level, right? Could we say strictly this sentence? Because if you compare with the mild protocol with the other ones and with the other FSH preparation, maybe we can get the same result.
Yeah. No, I didn't say that choline is better. What I said is that in the Engage and Endure study, in the dosages which were used, which is daily FSH 200 or 150, we had significantly less premature progesterone rise because we did a step down. Now, if you would do a mild stimulation in other group, obviously you would have less progesterone. On the other side, if you take a look at our application in human reproduction, more oocytes, more pregnancies, more oocytes, more cumulative pregnancies. So at the end, you want to have more oocytes.
Thank you.
Okay. Just last question from the back.
Hello, good afternoon. Samuel Ribeiro from Brussels, from where, by the way, you are very missed from, Dr. Fatemi. My question goes directly to you. You made a very specific comment which triggered my attention because it's part of my PhD topic, which you said that you give very much importance to progesterone variation when you are looking at a cycle. I have a pragmatic question for you, well, actually two. The first is, what is in your clinic your cutoff? Do you perform a cutoff of trigger progesterone? And the second one is, even with abnormal or normal trigger progesterone, is there a progesterone variation limit that makes you think of freezing all?
Thank you for both questions. So, first of all, the variation of progesterone was a PhD work of Leif Bungum from Copenhagen, who is working with Klaus Illing Andersen. So this variation is up to 50%, it's huge. And it's, by the way, it's not only progesterone, it's the same with AMH also. There are huge variations of AMH also. I always say it's cycle independent, but it's not. In our clinic, we have a dilemma. Where I work, we have several clinics. Our main clinic is in Abu Dhabi. In Abu Dhabi, freezing embryos is forbidden. So we're not allowed to freeze embryos. So if we have to freeze eggs. I don't have to tell you that I rather prefer freezing embryos than freezing eggs. So if I can avoid freezing, I avoid freezing. So what do? We do everything that we can to prevent the premature progesterone rise. Before I start, I'm not happy with the progesterone. Everyone would say 0.8, 0.9. So I try to bring down the progesterone to... I think the microphone is not working. So I try to bring down the progesterone to 0.2, 0.3 before I start stimulating. How do I do that? We know that part of the progesterone is coming from the ovary, part from adrenal cortex. You can administer antagonists to bring it further down, plus prednisolone, whatsoever, 1 or 2 days. Once it's down, we start stimulating, and we do a lot of fine-tuning. I never give from the first day to the last day of stimulation the same dose, never. I always fine-tune the last 3-4 days of stimulation, and I have to tell you, by doing that, you would avoid up to 95-96% of all cases having premature progesterone rise. Now, when you ask me, what is the cutoff level? That's a very difficult question. There are publications from Griesinger, also from Papanikolaou. If you have high responders, if you transfer blastocysts, even high progesterone seems to have limited impact. It has an impact, but it has limited impact. So you have to look, do you have a patient who has 6 or 7 eggs who has high progesterone? Or are you dealing with a patient who is having 18 eggs? The cutoff level is generally, in our clinic, around 1 nanogram per ml. Once we go above 1, between 1 to 1.2, 1.3, then we look, is it a high responder or a normal or poor responder? So this is where you have to be critical, not only looking at a certain value, but also at the patient, and also at the age and the number of follicles that you are recruiting with these oestradiol.
So in terms of questions, genetics couldn't have replaced endocrinology.
I want to add something. All the different treatments or options that Dr. Fatemi has been given could be understood from the genotype, phenotype as the environment. So every change you give, you make in your treatment, that is something that exposes to the patient to different conditions, and it will respond differently. And at the same time, you are seeing and you are some variability in the response of the patients, and that variability can have a genetic basis. And the example that Carlos has given regarding with lymphomas, in the 70s they only have one kind of tumor, but now they have 50 or I don't know how many have been said. Many of these can be classified based on the genetic alterations. So in the end, I understand that as knowledge increases in the genetics, we will be able to start to personalize the treatment of the patients based on the genetic background, knowing the way in which they are going to respond to the different treatments.
Okay, so thank you both of you very much for your great lectures. Thank you so much. We will give just 15 minutes of break for a coffee break. 10 minutes, I'm sorry. Thank you.